Okay, so big thank you to Dr. Jonathan Potts of the Royal Free Hospital, ERCP and EUS aficionado, liver transplant expert and hepatologist, for joining us on Gastro Learning Express. And he has very kindly agreed to talk to us about PBC and give us some snack learning for Gastro Learning Express. So thanks for joining us, John.
Thanks very much, Taz. Great to be here, and thanks for that introduction. Hope you can live up to that.
Of course you will. Present. You're sat in your liver clinic. How would you expect the patient with PBC to present to your clinic?
So the majority of patients are referred with asymptomatic liver biochemical derangement that's been noted on workup for other reasons. A substantial minority of patients do have symptomatology that either has been declared or sometimes only is apparent when on direct questioning. So a little over half the patients are asymptomatic with cholestatic liver biochemistry, and around a third would have symptoms such as itch, fatigue as the dominant symptoms of PBC. So I think the important thing to be aware of is that the symptoms are very non-specific, and particularly in the at-risk population, who are very frequently women in their 30s to 60s, there needs to be a sort of index of suspicion to start investigating those patients, and particularly in patients who've got abnormal liver function tests, potentially with a autoimmune phenotype, to consider the diagnosis.
Okay, so talking about the deranged liver function test, so you've got a raised ALP and a gamma GT and a clinical suspicion, so one of those phenotypes. Tell us about the liver autoantibody. What should we be checking in clinic?
So the basic panel that is diagnostic for PBC is anti-mitochondrial antibody, and specifically the M2 subtype. So that's considered pathognomonic as a serological diagnosis of PBC. And the vast majority of patients, over 95%, will be AMA-M2 positive. So there are a minority of patients who have AMA negative PBC, but those are the minority. So the majority of patients can be diagnosed readily from autoantibody testing that's normally available in primary care and certainly in most secondary care settings. And so the majority of patients that we're seeing in the liver clinics, certainly it's very frequent that they've been diagnosed in primary care on the basis of serology. It's not infrequent that we see patients who've got normal liver biochemistry but have had a panel of autoantibodies done for other reasons and have incidentally been found to have to be AMA-M2 positive. And the data from Newcastle would suggest that a minority of those patients do go on to develop clinically apparent PBC. And so those patients don't require treatment, but they do require follow-up of their liver biochemistry, often within primary care. So most patients, or it's very frequent patients, are referred to us with suggestive serology. I say a minority of patients may not have the classical serology, and there are other ways in which they could be identified.
Okay. So on that, is serology alone enough? When would you be reaching for the biopsy needle, if at all?
Yeah, so the threshold to biopsy these patients has risen considerably. So the availability of a highly specific serological test, plus the ability to stage the liver disease in general non-invasively with the aid of elastography, really means that we reserve biopsy generally for patients where there's diagnostic uncertainty, and sometimes in patients where there's a suspicion of a autoimmune hepatitis overlap with atypical liver biochemistry with a mixture of autoantibodies, etc. So those would generally...
so who do you treat? Everyone that comes in with positive antibodies and symptoms, or who are the people you're treating?
So anyone with a elevated ALP with a diagnosis of PBC, we would initiate treatment with ursodeoxycholic acid The target target dose is based upon weight, which is 13 to 15 milligrams per kilogram, and one's looking for a response to an ALT less than 1.67 times the upper limit of normal. So that's what defines an ALP response, and that's on the basis. So the data are on the basis of a liver biochemical endpoint, using that as a surrogate for for slowing the progression of advancing liver disease.
Okay, and so you're checking liver function tests annually in their clinic. Is there anything else that we should be assessing and looking for?
I think that the other things just to be aware of when one sees patients with PBC is the awareness of other coexistent autoimmune phenomena. One should be looking to assess patients we may have associated conditions, and particularly metabolic bone disease. So osteoporosis and osteopenia is frequent in these patients, and so and the population are generally at risk of that being women later on in life. So that should be actively investigated and managed. As you say, that the patients, once they're commenced on ursodeoxycholic acid, if they're deemed to be a responder on the basis of their liver biochemistry, then they can then have annual follow-up of liver blood tests and management then of any symptoms that are associated with PBC.
Okay, and if they don't respond, are there any other treatments, any second-line treatments?
Yeah, so obeticholic acid is the second line agent that people are probably aware of, and the evidence suggests that that may have benefit in slowing the progression of PBC in people who are judged to be non-responders after a period of treatment with urso. And that the time to consider this as a treatment is in patients who still have cholestatic liver biochemistry around 2 years into treatment with appropriate dose ursodeoxycholic acid. That applies for patients with non-cirrhotic PBC. And I guess the other things just to sort of comment on are that PBC, the nomenclature has changed to reflect that only a minority of patients with PBC actually have cirrhosis. So this is now primary biliary cholangitis, not primary biliary cirrhosis.
Just to finish off, we've got a lot of fantastic information there. Are there any kind of guidelines or any papers that we can direct our users to?
Yeah, so the BSG guidelines were published in 2018, and they really do sort of summarise the current state of play and the current recommendations within the UK, and they've got a very sort of easily digestible schematic going through the ways in which one diagnoses these patients, treatment and risk stratification, assessment of response, and the long-term follow-up, which is basically the standard surveillance for patients with cirrhosis if the patient does have cirrhosis, and consideration of therapy such as transplantation if that's appropriate, and then management of the symptomatic disease that may occur with PBC.
That's fantastic, John. Thank you so much for sharing your time with us and sharing those nuggets of information. Hopefully you'll join us again for another talk on PSC. But thanks very much, John.
Great. Thanks very much, Taz.